Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and yet another video about CBCTs and launching ortho in a practice with a CBCT machine instead of a traditional PANSAF. Do you even need one? This video is going to be for orthodontists, pediatric dentists, general dentists, really anyone, people who are considering getting a CBCT and or maybe already have one and want to know what they need for ortho, or maybe they're thinking about buying one and they're like, goodness, do I need to think about this in the future? So, first of all, just a quick disclaimer, I don't have a CBCT in our offices, plural. Um, we've actually gotten really lucky, the offices that we have. There is a dental radiologist with a CBCT slash dental radiology clinic at all of our locations within a mile and a half to 2 miles. Super flexible. They take it, they interpret it. It is not expensive, and they read the report. So why? And keep in mind that if you've got to practice in a very expensive area like San Francisco, New York, Honolulu, things like that, the Bay Area, it may not be affordable for you to be able to put that. Not talking about buying the unit. I'm talking about, depending on the laws, the space, the regulations regarding the unit, the protection, everything. It might not be worth the space because the space might be more valuable as something else, a consult room, an ortho room, a treatment room, an op, a surgical suite, whatever. So if you don't have to get it, don't get it because then you have no legal responsibilities. So that's the main things I wanted to say. But yeah, you need to have access to one for sure. So, I mean, obviously this is the newer way to do things instead of your traditional analog PANSAF. Obviously, if you have a PANSAF and it's working, unless you're doing endo, you're probably fine. Or OS or placing implants, probably you're good. So why, But if you don't have one, you've got a dental office, you're going to have to get something in there, right? So definitely considering a CBCT is not a bad idea. Obviously, try to see if it fits. If you have a traditional PANSAF or pan that you're trying to replace, it should just plunk right in. But you got to check it out. So, yeah, a lot of things to consider. Obviously, FOV or field of view is a big issue. So let's go over some of the things that I know about FOV or field of view. Smaller field of view, less litigation, less risks, because a small field of view means that you are interpreting less stuff. So a small FOV makes sense for an endo case or an implant case where you just need to know about that one specific tiny itty bitty area. Am I putting this implant in a nerve? Am I putting it in a blood vessel? Am I extracting this tooth? Is there something nearby? Has number 11 resorbed number 10? Might have. Or number 12, things like that. We can get that area, etc., right? Or let's take it on this tooth right here, whatever tooth this is. I guess it's like 20, lower right 4, or something like that. Yeah, lower right 4. Can I move this tooth buccally? How much bone is there for me to move it buccally? Just things like that. There's a lot of things you can tell from a small FOV that's still useful for ortho, but it's not going to give you the global diagnostics that you need sometimes. So let's talk about what cases would need global diagnostics. Well, any case that has a vertical issue or an AP or sagittal issue is going to need global diagnostics, most likely. Now, if the patient's not growing, then I don't necessarily need to know its relationship to the cranial base unless I'm worried about things, or maybe I do, because if I'm worried that there might be a condyle atrophy, or there's a lot of things that goes on in adults that doesn't really go on in kids, and a lot of things that go in kids that doesn't go on with adults, where I would still need global ceph, like global numbers. So when you have a big FOV, be it a 10 by 10 or bigger, I believe you've got 10 by 10, 16 by 16s, there's a bunch of different ones. The bigger it is, the more you can see what you need to see in terms of ortho. So obviously, if we need to know if a patient is growing and if a jaw is retrognathic, if I've got 2 cephs, one from last year, one from this year, and I'm trying to see if the lower jaw grew, or if the lower jaw grew more down and back, or if we're having more airway or vertical issues, then I'm going to have to see sella and nasion, which are, way up in the brain, in the base of the pituitary and the anterior portion of the nose, and as well as the teeth. So you're going to need the whole side of the head, which means you're going to have a pretty darn big FOV. So the problem is you can't upgrade an FOV from what I know. So sometimes you can stitch them together, but I've got one doctor that stitches them together. It gets kind of messy. I can't help you stitch it together. So, I mean, you got to figure out how to do that. And if you got to make sure your numbers are accurate if you're going to be stitching them together. So I can't tell you if that's something you're thinking about stitching, then you need to find out if you can do it, because I can't promise that that is doable. Let's see what else. So remember, whatever area that you image, so like if you're just imaging lower right 4 or upper right 3, you know what I mean? This apex area, well, it's unlikely you're going to get something random that you couldn't interpret. Tooth is buccal. Yes, there's resorption. Yes, there's some bone. But if you're taking a whole giant FOV, 16 by 16, well, some other stuff might show up that you weren't expecting, that might be medical stuff, and you might not be trained to interpret it. And if that was like a carotid artery that was calcified or something, or some type of pathology, and you didn't recognize it, you in trouble. So you in big trouble. So, and it's not a matter of if, but when. So I think if you're going to have a big FOV, you have to use something like a beam readers to read every single scan. And it's going to cost a little bit of money with every single scan or CBCT imaging. It's going to cost a little bit. And yeah, I mean, it's something you're going to have to bite the bullet unless you want to teach yourself how to do it. I mean, I know there's a bunch of AI programs and other stuff, and you could always run it through an AI program. And then if something came up, you could toss it. That's your choice. I'm not telling you what to do. I'm just saying your job, your responsibility. I don't do that. So I'm not a dental radiologist. I only look at the ortho stuff. It is not my job. I will tell you to use the beam readers to look at the condyles, look at resorption, things like that. Matter of fact, I'm going to even ask you to have them read it for that. I'm not reading that for you if there's pathology, although I can kind of tell if there is, but in any case. So yeah, there's a lot in terms of failure to diagnose, and it's risky, right? So like we said, FOVs, bigger FOVs for ortho are going to be at least a 10 by 10 up to 16 by 16. I think there's even 17 by 23 or even larger. You got to find out what you're going to need for ortho, whether you're going to need a medium FOV or a large FOV. Large FOVs are needed for ortho, orthognathic surgery, sleep apnea, airway, TMG study, TMJ or TMD studies, and any type of orthodontics where we're accessing, skeletal asymmetry or symmetries. No, you can't upgrade them, like I said. And keep in mind also that the CBCT, this is something that comes up. I see a lot in Facebook groups. Yeah, y'all, this is the patient's record. So if you are charging for this, you still have to give it to the patient if they ask. You can't decline it. And it's very iffy if you can, if you are doing this and charging for it with every ortho case, nobody's going to do ortho with you. So I'm just saying, I mean, general records are generally done for free for ortho cases. You can't usually get paid for them, and they're usually done for screening tools. Now, if you're using this as screening, I don't know if I would do it for screening though. I mean, it's just risky because anytime you take it for screening, you're also responsible to interpret the entire FOV. And then what happens if then now you got to pay for a beam readers to do it? No. So this is a tough call. So if you only have a CBCT, right? See what I mean? That's why I kind of like the analog paddles. So, I mean, this is just a lot of things to think about, right? So any patient should be able to have the right to their imaging. I mean, that's a fact, Jax. I mean, they're going to have to download. It doesn't mean you can you might have to put on a flash drive. It's going to be a giant file. That's their problem. And it's their doctor's problem. And you can have them pay for the flash drive. I mean, there's nothing wrong with that. You can tell them what size flash drive you need to put it on. I mean, I don't think that's unreasonable. I would consider that reasonable. To have copies of the content, but I mean, or you might have to transfer it within the cloud to another doctor to another cloud imaging. I mean, they do have a right to release it to another provider, so they can sign that, right? Obviously, the original dentist has to keep a copy of it for 7 years or 7 years after the patient turns 18. Check your laws in your states. You can have a reasonable fee for reproducing and mailing it, but I mean, this is digital, right? So why would you be mailing it unless you're nailing a flash drive? But could. So that's pretty much what I got to say about FOVs and just things you have to consider. So I'm not going to tell you what to do. This is your choice, your office. I'm assuming if you're getting a CBCT, you're using it for more than just ortho. So just things to think about. Certainly there's so much data you can get on screening a patient that does not require a CBCT. And I've been seeing some of these, I did this, some seat class last night, and it was like a general dentist who does a lot of pediatric ortho, and she was taking screening CBCTs with beam readers interpretations, which I agree with. I mean, nothing wrong with that, on every single kiddo in her practice, just to see if like the canines were buccal. Why you gotta do that? Just take a traditional I can tell if a tooth's impacted just by looking at the dentition. I can feel for it. I can just a regular PA. I can tell you if it's impacted. I feel like sometimes it's like a bright, shiny thing and it's a flashy way. Like, ooh, look, I have this technology. I can do this and I'm going to be the best. Doesn't make you a better orthodontist just because you're putting more radiation in the patient that's not even starting yet. I mean, to me, why are you irradiating a patient who's not starting? Like that kind of level of irradiation. I know it's not as dense as it used to be in a traditional pan-ceph, but still, unless they're committed to starting, I'm not doing that. No way. So there's a lot of stuff I can tell just from roughly looking at the patient. Do they need treatment, right? Then if we got to go into the nitty gritty, see if there's damage, we can take that CBCT once they've gone ahead and contracted. And you can contract, you don't have to have a firm total treatment plan before you contract, because sometimes you don't know until you get all the records. So, worst comes to worst, if they contract, they can always get out of their contract. This contract is not like a legal binding thing. I mean, if people need to cancel, there should always be in any contract for orthodontic treatment, there should always be outs in how things work once you're out. So there should be an option for them to cancel, and once they get just their records, they just pay for their records, $500. That's cool. That's fine. We finished taking our records. If you want to cancel now, be my guest. Obviously, once I slap braces on or take and submit for Invisalign, it's now going to be a lot more because I've already paid the lab fee and done doctor time and done time creating a treatment plan. It's going to be more. So everyone needs to have some type of contract so that you realize if and when you guys break up, and people break up, people change their mind, people lose their jobs, people have to move, people break up, people decide they don't want to do treatment anymore. There always should be an out. So never go and spend your entire money. If you get paid up front, you're insane if you spend every drop of that. You should assume that there's always a chance a patient might cancel and that money needs to be liquid. So be cautious. And that goes the same thing with paying yourself or paying your associates. You don't pay them full production up front. Are you crazy? I don't care if the patient paid. You pay them in drips and drops, like an insurance company would pay you in drips and drops, just in case they cancel. So see all my other content that I've made on paying associates for Invisalign or ortho cases. So, all right, thanks so much. Hopefully that was helpful.